to the fourth session of the virtual fellowship of WeAreSpine in association with OrthoTV. Today we are going to talk on a topic which has actually been mystical, which has actually been a very confusing topic for everyone. And that's how do we manage primary and metastatic spine tumors? The reason why this is a very complex topic is because the field is undergoing change on an everyday basis. There are new and newer updates which keep coming in, so the protocols keep changing. It is virtually impossible for someone to remember the treatment protocol for each and every type of tumor. But if you understand the logic, if you understand the concept of how we treat them, then you will be able to easily have a very good treatment plan for all of these cases. Let me begin by just quickly showing a case that had come across our way. And if I can have some volunteers to discuss out with me, either you pick or I will pick you. So fine. So here we have got this 11-year-old female who has come to us with neck pain. She has no radiculopathy, no myelopathy. On examination, her neck range of motion is restricted. That's the only positive finding. And that's the MRI of this patient. Anyone wants to volunteer? Kedar, you're there?
Sir, I'm here. Yes.
Tell me, what do you see in this presentation? Like what do you find in this MRI?
So the MRI shows loss of cervical lordosis.
Okay.
The cord appears to be there appears to be no compression on the cord, which is very grossly evident.
Good. Anything else you can notice over here?
The C2 to me appears slightly, but I'm not sure about the C2. No.
Very good. So basically, you have identified 3 different points in this. You have said that the cord is looking normal. There is a loss of cervical lordosis, and there's something going around C2. All of these are good findings on the MRI because, yes, you want to look at the neurology. It is unusual to have a neck of this sort in a kid. Yeah. And you have identified something in the posterior element over here. So I'll correct it and I'll tell you that it is not C2, it is C3. But you are at the right place. What do you see over here?
So there is a hyperintense lesion at the spinous process of
Okay.
C3.
What does that tell you?
It could either be an infective etiology, so I would ask for more. I would ask for
the further sections.
Yeah.
You've got the same T1 weighted image. What do you see now? It's totally okay if you're not able to figure out.
I'm not sure about this.
So fair. So what you did identify is there was a lesion in the posterior element of C3, which has a hyperintense, which is hyperintense in T2 weighted image, which looks to be like either fat or it can be fluid. Correct?
Yes.
Yeah. When you go in the T1 weighted image, what you're seeing over here is that the intensity of that is similar to the CSF, which means it is more likely to be fluid than fat. Okay. But I also agree with you that this is not enough. This is not something that is enough for us. And we want the axial cuts over here. And that's where we have got the axial cuts over here. Tell me, are you able to see something over here?
Yeah. There appears to be a lesion on the near the lateral mass of the C2.
Of the C3 vertebral body.
C3.
On the left hand side.
On the left side.
What other things you are able to see over here?
The cord in that area appears to be normal. There is no direct involvement at the cord at that level.
Very good. Very good. What else? Do you see the muscles around showing a lot of edema?
Yeah.
Yeah. And also, do you see that vertebral artery which is well away from the tumor?
Yes, both are noticed.
Yeah. So it is important to know that in tumors, your vision should be widened. You have to look at all different aspects. You have to look at that lesion. You have to look what is happening around the lesion. You have to look at all the important things which are in that area. So if it's cervical spine, you want to look at the cord, you want to look at the root, you want to look at the vertebral artery, you want to see what is happening to the other structures like the carotid, the anterior esophagus, trachea. So because when you're treating tumors, your vision has to be widened rather than typically looking as a spine surgeon where you're just focused on the spine. So after this, if you need some additional information, you go to the contrast images. So here we have a T1 weighted contrast image. What do you see here which you were not seeing earlier?
The lesion is well encapsulated.
Yes. Yes, Aditya.
So sorry, Priyank, I'm interrupting in between.
No, of course.
Just for delegate's sake, do you always advise a contrast MRI if you see any suspicious or suspected tumor-like condition in all cases?
Absolutely. So if you have a suspect of a tumor, it is very well justified to do a contrast MRI scan, because there are a lot of differentials that you can rule out with a contrast scan. And also there are so many other things that can help you plan a treatment. Like for example, here, this contrast scan is helping us tell us that the muscle that in the T1 weighted image, if you see, you will see like a mass and you're going to see muscles around. You are not very sure how much of that muscle is infiltrated. But as soon as you see a contrast scan, you can see very well that the muscle and the lesion are completely different. There's no infiltration of the muscle with the tumor. So if you're suspecting tumor, it's worth doing a contrast scan day one.
Okay, thank you. Thank you.
So by now we've got these all information. So what information we have? We have a 11-year-old girl who has no neurology, who has no constitutional symptom, neck pain, restricted range of motion. You have done an MRI showing loss of cervical lordosis. Cord is okay. There is a lesion in the left-sided C3 lateral mass, which is an expansile lesion with the muscles around the lesion, which is edematous. The vertebral artery, the cord, the roots are all free from the tumor. This is what we have now. Kedar, what more would you want over here?
I'd like to further investigate.
In form of?
Firstly, I would like to get a PET scan done to check if this is the only lesion or there are other lesions or mets that we can expect. Also, I'd like to get a CT guided biopsy of this lesion to check
Fair. So you want a PET scan and a CT guided biopsy.
Yes.
Do you feel that this is a malignant lesion, or do you feel it is a benign lesion?
Based on the present images that we have, it is not adequate information, but since it is a well encapsulated lesion, not infiltrated.
This is very good. So yes, based on the information, there is no adequate information to differentiate if it is benign or malignant. Correct? But yes, you do have the history.
Yes.
Right. So you're combining the history and the fact that you don't have enough, you would want to do something more. PET scan is a test which is not widely available, but you do have CT scan.
It is.
So the very next scan logically should be a CT scan because it's easily available, it is cheap, and it is there at all centers. Now, do you see the CT scan of this girl?
Yeah.
Are you seeing the CT scan?
Yeah.
Would you like to read it? What are you seeing in the CT scan?
It does show that the tumor is well encapsulated. It does have a bony margin around it. The vertebral artery has, there is a plane between the vertebral artery and the tumor and the lesion.
Okay. What else?
The canal is mostly not compromised.
Correct. No, you're absolutely fine.
Yeah, those are my.
So yeah, so basically, like just what Kedar mentioned, there is an expansile lesion in the bone involving the left-sided lateral mass of C4 without any with peripheral calcification seen. It is a well encapsulated lesion, not involving any important structures like the vertebral artery or the vertebral canal. And that very same thing is seen in the lateral mass, right?
Yeah.
So tell me, what do you want for this biopsy?
At this
Anyone
point,
else? Like Aditya, what would you want to do?
Hello.
Yeah. Is my voice okay? I got a message from
the
Virendra
voice
that my
is
voice is
No,
breaking.
okay.
Yes,
there's some
I
delay. There's some
Okay.
delay and there's some cracking of the voice, but I think it's better now.
Okay, fair. I'll sort that out. Harshal, you want to? Did you go through the entire case which I presented?
Yes, sir. Yes, sir. I
So
went through
what
it.
would you want to do? You would want to do a PET scan here, or you'd want to do a biopsy over here?
So biopsy at this point will key
But
because
why
I
not
don't know.
PET?
I have to find a very good radiologist who is gonna do a CT guided biopsy here.
Okay.
And I think it can be also a kind of a treatment per se, therapeutic also. So I would
So
I would
here, no. So here, you would want to do a biopsy, but Kedar, you said you want to do a PET scan, right?
I would like to do both the
Why
biopsy
would
as
you
well as
want
a
to?
PET scan.
Why
so
would
it,
you want to do a PET
it's
scan over
it's a
here, Kedar?
typical dilemma for me whether to go for a biopsy first or a PET scan first because this is a central nervous, this is a biopsy of a deep tissue. So if I can do a PET scan and find out there are multiple lesions which are superficial, I can do a biopsy from a superficial bone. So that's one point for me to do a PET scan earlier. But this
Okay.
is very classical, eccentric, expansile, solitary lesion, and my there's no other involvement anywhere in the because you must have done a whole spine screening also.
The whole
So
spine screening is done, and there's nothing anywhere
yeah,
else.
yeah. So these are the cases where I still would do a PET scan first, but
Okay.
biopsy also is the right answer. Yeah.
Okay, fine. So the reason why we had all these discussion over here is because that within a unit where all of us are functioning together, there's so much discrepancy. We have one person telling about the PET scan, one person telling about the biopsy, and that's actually the problem when we are treating with tumor, because there's no right answer, there's no wrong answer. Everything has to be tailored case by case, and everything that you want to do, you ask yourself the question, why are you doing it? Is it going to help the patient in diagnosis or in treatment? So here we have a patient whose history suggests that probably it is a benign lesion because there's no constitutional symptom, there's no weight loss. But again, these are all relative history. Like, you cannot completely bank on it. Your MRI is suggestive of a solitary lesion in the posterior aspect of the spine. The CT scan is showing a well demarcated lesion in the posterior aspect, which is easily accessible. So in this situation, my bet is more towards it being a benign lesion than a malignant lesion. That is why here I will safely go ahead and do a biopsy. I will also tell you something that Harshal already pointed out. But anyway, so this is what was done by the doctor. They put a needle into the mass and they did a biopsy, and that's the reply, that's the exact histopath diagnosis that the patient gave, that it looks like aneurysmal bone cyst with suspect of osteoblastoma. Aditya, you're there?
yes,
Harsha?
Priya.
Yeah. So what would you guys do now? You've done a biopsy, and that's where you've got a lesion, which is either aneurysmal bone cyst or it's an osteoblastoma. What would you do over here then?
So since this is involving a lateral mass,
Yes.
so I'll be and though CT is showing vertebrals are quite okay, there is a plane between, there is no involvement of vertebral. But
Yes.
since it's involving a lateral mass, I would
Yeah.
maybe we can just try for chemical cauterization in this case.
Okay. Chemical cauterization, which means you want to inject something in the lesion.
In the lesion.
Okay. Anybody? So you want to do a surgery in this patient, and here you want to just you want to inject something in the lesion. Harshal,
Yes.
what's your take? What would you want to do for this?
As the diagnosis is most probably a ABC or osteoblastoma, I think
Yeah.
I'll follow her up, because I think after kind of poking the needle inside, it would start organizing itself. So it may just resolve on its own. That's that. So I would observe her for some time. Yeah.
You would observe her. Is there anyone for surgery? Aneurysmal bone cyst, high chances of recurrence. Osteoblastoma is a locally aggressive lesion which requires wide excision. So anyone here wants to do surgery? Kedar?
No, I would observe and
Why
then
observe?
in a sequence of I would repeat the scans after say about 3 months with monthly or every 3 weekly follow-up to check the neurology.
But
And
why?
if it
You already know that the patient has a tumor. Tumor principle says that if you've got a tumor, you get it out. And here you have a proven part that it's a tumor. There's a query that it's osteoblastoma, ABC. Then why no surgery in a young patient? Why wait for it to become bigger in size, and then you end up doing the surgery where there's a chance you'll leave back the tumor? So would you not want to remove it quickly?
no, I
Anyone
would
else from our delegates? Anyone would want to do surgery? And if yes, then what kind of surgery you would want to do?
Sir, surgery. Nitin speaking, sir.
Yes, Nitin. You want to do surgery. Great. What kind of surgery you want to do over here?
Sir, wide local excision.
So when you do wide local excision, what are the things that you're worried about? Are you worried about instability in this patient?
Sir, that's a possibility, sir.
So in that case, you want to do a wide excision, and at that same time, are you going to stabilize this patient?
Sir, if intraoperatively, sir, while conducting wide local excision,
correct.
Sir, if to ancovertebral,
if you're going to damage your facet joints,
exactly, ancovertebral जो joint हैं, अगर वो मेरे से हो गए, तो फिर तो fix करने का.
Then you will stabilize it. Correct. So then you are going to keep implants ready, and if you feel at that time there is going to be an issue, you are going to stabilize it. Correct?
Ji sir.
Would you want to do something before would you want to do embolization in this patient before the surgery? You would want to do a pre-operative embolization for this patient. How many days before the surgery would you want to do the embolization? 1 day, 2 days, 5 days?
Sir, in general,
is there some specific time period? What is that ideal time for embolization?
Sir, in general, simple bone cyst and osteoblastomas are not highly vascular tumors. Or साथ में at the same time, the CT picture shows that.
Very good. So you know what aneurysmal bone cyst is. You know what? Yeah. Go on.
What, sir? So, sir, these are not highly vascular tumors. Number one. Number two, on CT scan we see, on MR scan we see that there is a distinct lesion with a reactive capsular tissue formation around it. So some sort of pseudo capsule preventive mechanism has been done by the body. So in these two concerns, it seems that wide local excision would be a possibility, and pre-operative or preemptive some kind of angio procedure is not needed in this case, sir. Yes, sir. I'm done, sir.
Okay, great. So these are very good points from everybody. But if you notice here, for this one single case, we have got so many different opinions. And when I was actually dealing with the same, yeah. So in this same patient, we had so many different types of opinion coming on from everyone. And just like how you all gave me all these opinions, I also got similar opinions from a lot of people.
Sir, one more thing, sir.
Yes,
Sir,
Nitin.
sir, when you were asking that question about PET thing and biopsy thing to Dr. Harshal, one thing came to me.
Yes.
कि क्योंकि देखने में, as you were saying, कि on our clinical observation, it seems to be a benign tumor, and
Correct.
there happens to be a good defense from the body side, and
Correct.
and God forbid something of out of blue can come up. Let's do this thing. Let's do the PET scan and then take the patient for OT and do a wide local action. That becomes the excisional biopsy itself. So that was another thing.
Fair. So here what we had different opinions is there were some people who wanted to wait and watch. There are some people who wanted to operate by doing a wide local excision. Nitin came out with a very excellent point that even if we don't have the facility of doing embolization, because he knows that aneurysmal bone cyst and osteoblastoma are not that vascular, we could go ahead and do the surgery even without an embolization. He pointed out that when we are doing the surgery, there is a chance that we are going to destabilize the spine and we might have to keep implants ready. And he also told us about two different things. The one part is that
Sir, I want to ask one
Yes.
question. Sorry to disturb you.
Yes. No, Arshad,
Yeah.
please go.
Yeah. So just I thought somebody will point it out, but that's why I had kept it away. What is the role of denosumab ABC? Just for the sake of it.
Very good. So now we have one more opinion of denosumab or some medications to take care of the tumor. Anyone wants to take it?
Yes, sir. Yes, sir. Sir, as far as the role of this denosumab is concerned, sir, when there is lot of soft tissue component to the tumor and there is lot of vascularity to the tumor, so that we don't that it is difficult to see the plane between the whole process, and you think that it would be difficult. It would be rather a large resection. So therefore, keeping these things in mind, then denosumab is considered. But when already there is a very good response from the human body and it is already small, dense, I don't think there is any point of considering denosumab when
So
ABC and osteoblastoma are the underlying HPE.
Correct. So what basically Harshal just mentioned about denosumab and the previous drug that we had, zoledronic acid, these are usually medicines which are given in osteolytic tumors in order to prevent a lot of bone resorption. And denosumab has now started showing, good results in management of giant cell tumors. So in this case, particularly, there is no role of denosumab, but denosumab as a medicine is widely being studied right now, and it's used as a very powerful tool in a lot of tumors. So coming back to why,
sir, one more thing, sir. Sir, one
yes,
more thing.
yeah,
Sir, when it comes to the GCT, the GCT itself is sort of an enigma. But sir, if we find that GCT seems to be very vascular and there is lot of soft tissue component and there is no plane available to make the surgery easier and to ensure that my margins are all intact. If these are the challenges, then within only this subset of GCT, denosumab holds a role. Otherwise, no.
Very good. So after having said this, I will quickly just show what exactly I ended up doing for this case. So like how I asked all of you, I took multiple different opinions. And after taking multiple different opinions, I got exactly similar opinion like you guys. And you know what I did? I didn't do anything. I just waited and watched. And you see what has happened over here? The lytic lesion has completely calcified over time. And this is the girl at probably a year when I had seen her and taken her picture, having complete range of motion without having undergone any surgical resection. There is no long-term morbidity. The only thing that the patient had to do is live with pain for maybe 5-6 months, which was controlled very well with just basic NSAIDs. The reason why I have brought up this very specific case over here is to tell you guys that tumor is something. It's like a jigsaw puzzle. So whenever you guys actually have a case of spine tumor, it's literally like you're going to have it's literally like you're playing along a board, and there are so many different questions that you have to answer and come up with a solution for this patient. And if you have these information about tumors at hand, then you will be able to take a much better decision for the patient, and something which could have had a major surgical event, like lateral mass excision fusion in a growing child is not simple. You have to do the surgery proper. The bone quality is not good. Fusion is a problem. It's a growing spine, so implant cutout happens at a longer time, and it would have been a big mess on my head. On the other hand, since I knew that it was an aneurysmal bone cyst, and I knew that there are case reports where just by breaking the cortex of the aneurysmal bone cyst and aspirating the fluid, there are chances that they show spontaneous resolution. I applied this same thing to the spine after having discussed with orthopedic oncosurgeons who have long follow-up of long bones. Just applied the same principle to the spine, and we have a fantastic result over here. So that's basically what happens in tumor, and this is exactly what we are going to do here today. We are going to go back with a brief idea of all the different types of spine tumors, what are their characteristics, and then I want each and every one of you to start thinking like a tumor surgeon and have a protocol in your head. So by the time you execute that protocol, you will have a correct answer of how to deal with that very particular patient. All right. So I'm going to start off with my talk, which will cover all the bases of different types of spine tumors. And eventually, yes.
सर आप कह रहे हैं कि सर वो जो बायोप्सी लिया, तो वो जो नीडल डाला उतने ही से आप कह रहे हैं कि वो वाला काम हो गया,
उतने में ट्रीटमेंट हो गई.
Okay.
So I was given exactly all these opinions that you had, and then I had the case reports with me. I discussed with the parents. They were very educated people. I told them that, see, there's a very high chance it's just an aneurysmal bone cyst. And there are reports where it will automatically calcify. But if it turns out to be an osteoblastoma, we repeat an MRI after 3 months. And if that is not happening, then we will go ahead and do the surgery. They agreed. And after 3 months, when we did the scans, we started seeing resolution and calcification. So that's where understanding the tumor is also important. And that's where we talk about spine tumors as a subset of spine pathologies, where primarily we deal with two types of tumors in the spine. We deal with the primary spinal tumors and the metastatic tumors which have come into the spine. Now, if you talk of primary spinal tumors, they make only 10% of all bone tumors, which is very, very, very rare. But on the other hand, 80% of all tumors are going to metastasize to the spine. And as people are living longer and living well with chemotherapy becoming very strong, we are now dealing with a lot more symptomatic patients of metastatic spine tumors, which we need to deal with. When we were discussing about our cases, we realized that we operate for several indications. One reason why we do surgery is to establish diagnosis, like doing an excisional biopsy. The other indication for surgery in spine tumors is for management of tumor pains. The next indication is where there is a compromise of the neurological structure and the patient is having neurological deficit. And lastly is where the tumor has caused significant instability in the spine, and these patients have a lot of instability type pain. So these are the reasons that we have been operating tumor from donkey's years. Then what has really changed? You think the indications have changed? Not really. The expertise, maybe a little bit. Approach, definitely. Today, it is the spine surgeon who decides how to treat a spine tumor. And oncophysicians, radiologists, radiational oncologists, and oncosurgeons give them a helping hand. But it is the spine surgeon who should take the onus on himself and take the decision. Just like how orthopedic oncosurgeons take decisions for long bone and other bony tumors. In general, whenever you talk about primary spinal tumors, there are two sets. You have benign tumors and malignant tumors. In benign tumors, you've got osteoid osteoma, osteoblastoma, osteochondroma. aneurysmal bone cyst, hemangiomas, giant cell tumors, and eosinophilic granulomas. So these are the basic tumors which you're going to see as primary spinal tumors. The malignant tumors, on the other hand, are chordomas, chondrosarcomas, Ewing sarcoma, osteosarcoma, lymphomas, and multiple myelomas. Uh, a very simple way of understanding the pathologies of these malignant tumors are chordomas and chondrosarcomas are cartilage-based tumors. Ewing sarcomas, osteosarcomas are sarcomatous tumors. They are soft tissue tumors. Lymphomas and multiple myelomas are blood cell associated tumors. Now, you need to know a little bit about the pathology of the tumors if you're dealing with them, is because a lot of times the pathological report is not going to be absolute. It will say that you're seeing some giant cells, some plasma cells, some spindle-shaped cells. So you need to know what you're looking for. So it is worthwhile to spend some time understanding the pathology also if you're dealing with tumors, and have an excellent pathologist who is used to dealing bone tumors. Pictorically, these tumors have affinity to certain aspect of your spine. Like chordomas and Ewing sarcomas, typically you will see towards the end of the spine, like the sacrum, whereas giant cell tumors and hemangiomas are seen in the body. Osteoid osteoma, osteoblastoma, aneurysmal bone cysts, chordomas, and osteosarcomas are something that are very commonly seen in the posterior element. But this is not an absolute rule. So it can exchange. But these are where maximum of the tumors are going to be seen. Let's talk a little bit about aneurysmal bone. Yes, Nitin.
Sir, any particular reason for these predilections? कि ओ sacrum में आता है, ओ body में आता है?
Yes. So the thing is, na, just abhi chordomas, if you see, they come from the primitive neural tissues, and with the way the embryology goes, it's in the ends of the spine where they are commonly seen. So if you ask, and now hemangiomas are tumors of they are basically blood cells. And vessels are seen, like body is richly perfused with the vessels. So hemangiomas are very commonly seen anteriorly. So that's the reason why there are few things where you have an explanation. There are few things where you really don't have an explanation. But if you look at the statistics, you see that these are more concentrated in these part of the elements. And I'm sure there is some embryological aspect to these type of affinities, but I'm really not in that. I'm not able to explain that in that basis, because even I have not gotten so much in detail. But if you actually talk to a pathologist, they'll probably be able to tell us better. But then, like what Nitin you were telling, if you know a little bit about the tumors, then you'll be able to plan them so well. Like let's say aneurysmal bone cyst. So aneurysmal bone cyst is basically a benign tumor, and it is seen in the vertebral column in 3 to 30% of all cases. The patients are usually young patients, and typically they have night pain seen in the posterior element. The MRI is going to show cystic lesion with air fluid level. So typically you can see in the lesion on an MRI a part of fluid and the part filled with air. So these are typical signs of aneurysmal bone cyst. When you see a CT scan, you will see an expansile lesion with good bony demarcation. So when you get a visual impression of ABC, when you see all these images, you know that you're looking at an ABC. And generally, the treatment that has been described for this is surgical resection, because they're notorious for recurrences. There are other alternatives that are described. That's denosumab, embolization, cortical breach, aspirations. So you should know generally what are the treatments that are described. So yes, aneurysmal bone cyst requires a wide excision, but like Harshal and Kedar said, Harshal mentioned that you wait across for some time and there is a possibility that it might calcify, and that's exactly what had happened. So that's a little bit about aneurysmal bone cyst. This is a case of aneurysmal bone cyst earlier where where the cavity was opened up, it was curated, and inside a bone chip was placed because there was additional instability in this patient. A posterior wiring and fusion was done. Yes.
Yeah, I'm not sure, but can anyone else see the
we aren't able to see the slide, sir.
You're not able to? Okay,
no,
just one second.
Since then.
No. Let me just check. Just give me 1 second. You've not been able to see any of the slides?
No, not till now, except for the case.
Oh, okay. So, yeah. Just 1 second. Huh? Now, are you able to see?
Yeah.
You're able to see now?
Yes.
Great. So basically what I talk about is the two different types of tumors that we deal with. That's primary and metastatic bone tumors, and indications why we operate on these tumors. Now, the thing is that the indications has really not changed. The expertise has gotten a little better, but approach is definitely changed now. And this slide is something that you should remember. And whenever you get a tumor in front of you, shut your eyes and look at this slide, and you will get an idea about what you're looking at. So immediately in front of you, you're going to get a differential diagnosis of benign, what all can be the possibility, malignant, what all can be the possibility, and then you start removing one after the other. This slide will give you a brief idea about what are the groups of tumors. So you have the anterior lot, the posterior lot, and the end of the spine. Okay. Then it comes to the what I was talking about, aneurysmal bone cyst. And that's basically a case of aneurysmal bone cyst where a surgery was done, an intralesional curettage was done, putting in bone graft and stabilized from the past. This was done way back around 20 years ago. And that's the time we used to use wires for stabilization. Now there are different types of surgeries that are mentioned. So in this patient, in aneurysmal bone cyst, we injected cement intraop for getting a quick rigid fixation, reconstruction of that tumorous area, and stabilized it with the help of pedicle screw and rod. This is a third type of case where we did just the one that I just showed, where we just did a cortical breach, aspirated, and that was the end of the story. So basically, for one single tumor, there are so many different types of treatment that is there. You should know what is the best treatment for your patient, and you have to execute that. Then let's go to the next type of tumor, and that's giant cell tumor. Now, giant cell tumor of the spine is a rare benign tumor. It is a benign tumor, but it is locally aggressive. And there are reports of giant cell tumors which have metastasized to the lungs. So usually the rate is around 5%. Typically, the patients are going to just present with pain, and some might come with bowel bladder dysfunction. That's one of the other reasons why we tell patients, why we tell everybody that if you're treating a patient with, if you're treating a spine patient with back pain, and after adequate conservative treatment of 3 to 4 weeks, the back pain is not going down, don't shy away from getting an MRI done, because the commonest complaint of patients with tumor is going to be nothing other than a back pain. And here in giant cell tumor, the treatment that is there is either wide excision, along with radiotherapy, embolizations, or denosumab. So this concept of intralesional curettage, wide excision, these are things that you're going to hear. And when we talk about the surgical principles, I'm going to explain what all of that means. This is a case. Yes, Nitin.
Sir, I was just wondering, sir, when it comes to this spondylodiscitis, sir, this itself is a painless structure, but there is some pain. So one thing is why that pain is. Second, when we look at these tumors, does the pain happens because of the mass effect thing? And third question is, how do you characterize this instability kind of pain? These are the three things I was wondering, sir.
Okay. So see, basically the pain in tumors can be bony pain because there is expansile lesion in the bone, and that is the reason why it can cause bony pain. The tumor can destroy the facet joint, causing instability, and then you can start getting instability type pain. Or it can grow and press some important structure, and it can cause a mass effect. So let's say there is a paraspinal tumor which is growing, which is pressing the psoas muscle. You're going to have a tight paraspinal spasm with pain, and that's because of the mass effect. And instability pain is going to be typical pain where the range of motion is going to be painful, whereas a tumor pain is something which is going to be pain at all the time. When you're resting, when you're moving, at all time that pain is there. So that's how it is. As far as the spondylodiscitis part you discussed, that because in spondylodiscitis there is something called as spondylo also, which means that even the bones are involved, and that's the reason why you have that typical pain of spondylodiscitis.
Thank you, sir. Thank you, sir.
Yeah. So
sir,
this
how
is
will you manage the recurrences in the GCT? You have in last slide you had discussed that it is a benign type of tumor in L5.
yes, yes.
But when the recurrence occurs, do you have the aggressive steps to be taken during that?
Correct. So exactly what you are saying is what is a dilemma for everybody. That if giant cell tumor is a benign tumor, so why do you remove the tumor? Because it is causing pain and mass effect. But when you remove the tumor, what happens if there's a recurrence? And that is exactly what I'm trying to explain. And at the end of the talk, you'll understand how are you going to deal with all these things. Yeah, but always remember, a tumor which is locally aggressive, you want to remove it wide margin day one so that the recurrence rate is the least. And then if there is recurrence, then there are other types of treatment. There's resurgery, there's adjuvant treatment like denosumab, or there is, so these are the different ways by which you deal with the recurrences. So when you decide on the treatment plan, you are supposed to plan all of these things. You have to plan how will you operate by doing least damage to the structures around. If there is recurrence, how are you going to deal with, and what all can you do to make sure that there is no recurrence? And that's basically the two principles that we want to discuss. But before we go to the principles, if you get a brief idea about the different types of tumors that we are dealing with, then you'll be able to understand the principles better. So like in this patient who had a case, which was
when it comes to this GCT, I just want to re-emphasize what you said, sir. This WHO have some association of orthopedic, and then this thing. So they have made 3 classifications: benign, intermediate, and aggressive. And so this GCT for last 2 classifications, over last 2 attempts of classification, GCT has been pulled out from the benign and put in intermediate. So therefore the dictum that they argue is that you treat it in the first go itself, as you said, that कि ये तो boss, ये तो aggressive और malignant चीज है, तो उसको benign मानो ही नहीं operate करते समय.
Correct, exactly. And that's exactly what happens. So there are so many different groups which are trying to get newer and newer protocols out, which is what I exactly mentioned in the start, that this is such a complex topic because on a day-to-day basis, there are updates that are coming in. So like this simple example of this patient with GCT, which was again tackled 20 years back, and this guy is still alive with multiple recurrences. He had a surgery in the front, which was excised and stabilized. He did well. And after 10 years, this patient developed recurrence, which was again operated, reconstructed. And this was still around 8-10 years back. And this guy is still alive. And right now we are treating him for a conservative lumbar spine problem, like a disc. So that's basically what has happened. And if this patient actually taught us so much about giant cell tumor, because this is that one patient we have been following up for so many years. So now we know how the recurrence pattern are, how to deal with recurrence, all the problems that happen with recurrences. So that's basically what you all also need to generate in your head, how to plan a tumor surgery.
I think one more point.
Yeah,
basically, the histopathology report also kind of tells us a lot about recurrences. So if you have some pleomorphism, mitosis and everything, necrosis and all, so these are all the signs where the GCT is supposed to be aggressive or atypical or malignant. And I think those are the cases you should be worried about, I think.
Correct. So Harshal has actually brought out one more important point, and that is about the grading of the tumor. That's why you need to also know a little bit of pathology. So actually, when you start deciding that, okay, now I want to start treating spine tumors, then you have to be a little bit of radiologist, a little bit of pathologist, a little bit of oncologist and radiation oncologist, so as a decision. Coming back to our primary tumors, we have hemangiomas, which are other common tumors that we see, and they are one of the commonest benign tumors in the spine. They are asymptomatic. They are incidentally found in so many of the MRIs. Like you have patients panicking that we have hemangiomas, but it's very normal. It is seen commonly in the vertebral body and also sometimes in the posterior elements. And a common area is in the thoracic spine. X-ray typically shows your jail type of an jail bar type of appearance, and MRI is going to have high intensity on T2 weighted image, and you have that typical speckled appearance on the CT scan, which I have shown here, which when you see, you cannot miss. It is a hemangioma. Again, if treatment for this tumor is needed, then you have options of wide excisions, intralesional excisions, serial embolization, vertebroplasty, radiotherapy, do nothing. So again, there are so many different treatment options that are described for this. And usually they need to be operated only if there is a collapse causing instability because of the fracture, or in certain situations, they become aggressive, spill over into the canal, and they cause neurological deficit. Like this patient. Now, this patient had, if you see, there is a D5 hemangioma that you're seeing, which has spilled over and it's causing cord compression. And this guy was treated, although there was cord compression, just by doing serial embolization, the patient did very well. One other patient who required surgery where a transpedicular decompression was done and stabilized. Now, this patient, if you would have touched without doing an embolization, the patient would have bled on the table. So knowing which tumors are bloody tumors, where you're going to lose bloods, you should know about all these things, and there is where mandatory embolization is required. Like to that extent, I would say if you don't have embolization at your center or in your locality or in your city, you refer it to a higher center, but don't touch them. This again is a case of hemangioma where only a vertebroplasty was done and the patient was taken care of. The next tumor that we have is osteoid osteoma. Now, osteoid osteoma are again rare primary bone tumors.
Dr. Priyank, sir.
Yes.
Sir, I was wondering, are there any at-risk signs about hemangioma that would tell that this hemangioma will need something rather than doing anything that compression has occurred? Is there anything before that can be picked on MR or anywhere that it needs to be treated?
No. So I'll tell you how. If you have an hemangioma and if you see that there is some soft tissue around the hemangioma in the paraspinal space and in the epidural space, those are and the patient is complaining of pain which you cannot explain, which is not a spondylotic pain, and these are the patients like this type of MRI you see, these are the hemangiomas you want to treat. Hemangiomas are known to increase during hormonal changes, especially in women. So a pregnant lady with back pain and hemangioma, that is something that you need to watch for, because during pregnancy, you can suddenly see a flare of the hemangioma, but immediately as soon as they deliver, it gets sorted out. So some telltale signs on the MRI showing a lot of paraspinal uptake and history of pregnancy and going through hormonal treatment. These are all the hemangiomas you want to watch.
Okay. Sir, I was thinking about a hemangioma which is like sitting well in the center of the body but not touching the plates, and there is hemangioma which is like a ball touching upper and lower plate. So nothing like that.
No. So that is basically where you're looking for reasons for surgery. Like if the patient has a full body involvement but there is no pain, range of motion is fine, there is no instability, nothing needs to be done for that patient. The patient had that hemangioma maybe for years together. But that same patient suddenly, if complains of back pain, if suddenly complains of instability pain, like when they are turning positions or have started developing neurology, then they of course need to be looked at.
So I would just like to make a point here. So very valid point, Dr. Nitin. Basically, I too always had counsel all these patients for surgery when it was like end plate to end plate kind of a hemangioma or involving completely the vertebral body. But most of them kind of ended up after knowing everything, got conserved. And I've never found them having any major issues. But one point which I've learned over a period of time is that if there's an end plate fracture which has happened, I think though that is a tricky point where I would definitely observe, I would definitely aggressively treat them, but nothing else. Yeah.
Great. So going back to our primary tumors, we now have osteoid osteoma. Osteoid osteoma, again, a tumor which is seen in males in their 20s to 40s more than females. Commonly seen in the posterior elements, the classical nidus or the size of the lesion is less than 2 centimeters. This can actually cause severe, painful scoliosis in patients. So young kids with scoliosis and a lot of back pain, your suspect should be that there's a possibility there's osteoid osteoma. Typically, it is seen in the convexity of the curve. And the treatment for this is either you excise the nidus or you do a high frequency radio ablation. Like this posterior element tumor where after the surgery the excision was done, and that's the end of the story. Osteoblastoma is similar to osteoid osteoma, except the lesion is more than 2 centimeters. Here it is much more aggressive and less common than osteoid osteoma. It is found commonly in the posterior elements in the male teens. And the treatment for this is not just removing the nidus or curettage. It's actually wide excision, and a lot of times they cause a lot of instability, so an additional fusion has to be done. You have to keep a watch on them because they can recur. That means you need to have a lifelong follow-up, and there is a real chance that it can convert to a osteosarcoma, and that's the reason why you have to do a wide excision rather than an intralesional curettage like what you would do for an osteoid osteoma. Now comes the malignant tumors. So I'll quickly just name the benign tumors. Just forget about everything. Just remember that in your head. You keep doing that. You've got your ABC. You've got your GCT. You've got hemangiomas. Then you have got osteoid osteomas, osteoblastomas. Then you've got fibrous dysplasias. So these are the common benign tumors of the spine that you have to deal with. Now you've got the malignant tumors. The one is chordoma. It is a rare malignant tumor. It is slow growing, but it is malignant. So it can metastasize. It arises from primitive nervous tissue systems. They are slow to metastasize, and 50% of them are seen in the sacrococcygeal area, seen in the elderly patients than the young patients. And the treatment for these patients are surgical excision. Remove it, throw it away from the body. A wide excision is the best form of treatment. Radiotherapy can be given, but it does not work. There are different forms of radiotherapy which would work, and that is what I'm going to talk later. What is radiotherapy and what are the types of radiotherapy? Remember, the patient is going to live long. So here you want to make sure that you remove it completely. And if you don't remove it completely, remember that you will have to operate this patient again in your lifetime, because there are very, very high chances of recurrence and they live long. Alternative therapies similar to radiotherapy are proton beam therapy and carbon ion therapies, which show better results in these type of tumors. So that's chordomas. Then you have chondrosarcomas. Chondrosarcomas are basically malignant cartilage forming bone tumors. They are typically low grade. These tumors can arise from a pre-existing cartilage lesion such as osteochondroma or enchondroma. So those tumors should be looked at, and it's very rare in the spine, but when it's seen, it's middle or older age groups, males more. The treatment for generally it is the prognosis is not very good because they are detected so late that it is almost impossible to get a wide excision in this tumor. Sometimes when you cannot do surgery for this tumor, you can do something called as radiosurgery, which means do surgery with radiotherapy. Again, a new thing which has come up, and I'll talk to you about it. The next type of tumors are Ewing sarcoma. Ewing sarcoma are again rare tumors, and they account only for around 3 to 15% of all primary bone sarcomas. It is the second most common primary bone tumor in pediatric population. So in pediatric population, whenever you get a bone tumor, primary bone tumor, think about Ewing's. It is very common. It is seen in young males, especially in teens. And the treatment for this tumor is primarily radiotherapy, chemotherapy, with certain situations where you do surgical resection. And it has got around 20% 5-year survival rate. So this is one of the tumors where you don't
Sir,
operate
one
without
question.
Yes, Nitin.
Virendra.
Hello. Yeah.
Sir, one question for Ewing's. In pediatric
Yes,
age
tell
group, Ewing sarcoma is common in middle shaft like tibia or femur. And when it is
Correct.
metastasized in the spine, will it lead
Yeah.
to the second metastasis like tumor, or it will the having the same type of pathological picture in the Ewing's in the spine? What will be the
No,
issue?
so it is good. So you are talking about a bone, a long bone Ewing's which has metastasized to the spine,
Yes.
right?
Yeah.
So it is going to present itself as a metastatic spine tumor. So usually you're going to have bony involvement more than soft tissue involvement. But so the radiological presentation is going to be like a metastatic spine tumor. But if you do a histopathological examination, it is going to be exactly like what your primary tumor is. All right?
Okay, thank you.
Yeah. So then you have multiple myeloma or plasmacytoma, which is a blood cell dyskaryosis, which is basically a blood cell tumor. 5 to 10% of patients with plasmacytoma, the disease may be manifested as a solitary lesion, which is called as plasmacytoma, or multiple lesions in the bone, which is called as multiple myeloma. Again, common seen in elderly age group, and the treatment is primarily radiotherapy and chemotherapy. Surgery only for instability or neurology. So that's basically all the different types of primary bone tumors. And today, what our main focus here is going to be, not look at the micro planning of each and every tumor, but look at planning of tumor holistically. So any weird looking lesion comes in the MRI, your brain starts thinking about what it is rather than getting completely lost as to, oh shit, what the hell is happening in the spine? You know that. So before I'll just leave you here for a minute for you to see all these things. Just give me a second, yeah. Just go through this slide again. Pull out your cameras and take picture of this slide. And whenever you get a tumor, start ruling out each and every differential. So these are basically the tumors that you're going to end up dealing with. Okay, just go through them once. And if there is any questions till now, I will want to solve it before we go to the next aspect.
Hello.
Yeah. I think Dr.
Sir,
Priyank is, I think. Yeah, bolo.
Yes, Dr. Bam.
Yeah, bolo na.
Is there any difference between the chondroblastoma tumor and chondrosarcoma tumor?
Yeah, it's actually a malignant conversion of a chondroblastoma, the chondrosarcoma. Chondrosarcoma typically are significantly aggressive and have a very kind of a poor prognosis per se.
Chondroblastoma itself is a malignant tumor.
Hello?
Yeah. So you asked something about chondroblastoma and
Chondroblastoma,
chondrosarcoma,
right? Yeah.
So basically the difference is that chondroblastoma is a benign tumor and chondrosarcoma is a malignant tumor. So that's the primary difference between the two. And then that's where your entire treatment plan changes for that. Okay? So, guys, I know that 50% of you might have already dozed off by now because, again, it is a very theoretical topic, but it's time to wake up, grab your coffee because now is the money making time. How will you deal with a tumor when it comes in front of you? You know now what the primary spinal tumors are. So, if you see a funny looking lesion, it's either a primary spinal tumor or it's a metastatic tumor from some place into the spine. Uh, you know what are the different benign tumors, you know what are the different malignant tumors, you know how they look on MRIs, what how benign tumors are going to look, how malignant tumors are going to look. How do you treat them? So one thing is, whenever you get a tumor, this is what you have to look at. What all are the investigations you want? Why do you want the investigations? Because you want to stage the tumor, you want to find out, and to stage the tumor you want to find out what exactly it is. So tissue diagnosis is needed. In order to treat the patient, you want to know how long the patient is going to live. Uh, in order to treat the patient, let's say if the answer is surgical, you want to know if the patient is fit enough to undergo that kind of surgery. And then finally, you come up with a treatment plan where either you're going to offer patients a curative treatment or a palliative treatment. Curative treatment means your target is to remove the tumor from the body and not cause recurrence. And palliative treatment is where you are not intending to cure the patient, you want to make them comfortable till the very end. And after this, you come up with a plan of either surgery, chemotherapy, or radiotherapy. So, what do you do now? You want to stage the tumor. Why stage the tumor? Is because based on staging, you can make a treatment plan. Now, primary bone tumors are classified as S1, S2, and S3. S1 is a latent primary tumor, you don't bother. S2 is a primary tumor which is getting active, and S3 is a tumor which you want to treat. So these are the three different types of, this is a staging for benign bone tumors. When you have malignant bone tumors, there is something called a stage 1A, 1B, 2A, 2B, 3A, 3B. Now, again, what it means that you have, when you're talking about malignant tumor, you're looking at the compartment. Is it in the compartment or has it breached the compartment? And what is the type of tumor? Is it a low-grade tumor, which is not going to be very bad, or is it a high-grade tumor, which can quickly change its form and start transferring at different places? So that's where the pathology or the what comes in the histopath is important. So you have you have 1A tumor, which are low grade tumor, which are within the compartment, and then you have low grade tumor which is breaching the compartment. Then you have high grade tumor which are in the compartment, high grade tumor which are breaching the compartment, and any of these tumor, when they metastasize, they become grade 3. Now, why this staging is important? Because how do you treat the tumor? You want to treat the tumor based on what stage it is. So for example, if you have a high grade tumor which has spread across, it is stupid to spend time treating that very tumor which you are seeing, because the patient will die because of all the metastasis that has happened. Whereas if a tumor is grade 1A, it is within the body and it is a low grade tumor, and you know that you can remove it and throw it away. By doing that, by executing that surgery, you are giving cure to the patient. You are making sure that the tumor is never going to come in. So staging is going to help you decide how much efforts you want to push behind this patient and what are the different types of treatment you want to do. Are you guys with me till here?
Yes, sir.
Great.
Yeah.
So in order to stage, you realized what you need. Number one, what you need is the MRI and the CT to see where exactly the tumor is. Then, in order to stage the tumor, you want to know what type of tumor it is. What is the grade of tumor? Is it a low-grade tumor or a high-grade tumor? Now, what you mean by a low-grade or a high-grade tumor? Whenever you take a sample of a tumor and you look under the slide, you see the cells. You see how much mutation has happened in the cell, how much the cells are differentiated, or are they looking like a funny mess where you're not able to differentiate it. Where you can actually identify and differentiate the cells, they are called as low-grade tumor. And where you can't identify, they are called as high-grade tumor. And high-grade tumor are notorious to spread. That's why when you have a high-grade tumor on histopath, that's a bad news. And in order to know the grading, you need to know the tissue diagnosis. And tissue diagnosis basically is going to talk to you about the grade of the tumor, and it also will tell you if that tumor is sensitive to certain targeted treatment. Now you've got so many immunotherapy that is available. Now breast cancer is a tumor you would not want to be worried about, because now you have hormone positive, hormone negative, and accordingly you can give medicines and patients can live years together without any problem. So that's where the tissue diagnosis is going to help for grading and targeted treatment. Now it can be of different types. I'm sure you have heard about this. There is something called as FNAC. There is called as bone biopsy, CM guide, which could be CM guided biopsies, UHG guided biopsy, or CT guided biopsy. There are a few principles that you should remember over here. That the bigger the bore, the better it is. Multiple different areas of the tumor should be targeted to get multiple different sections which you can study. All the samples should be collected together and sent to one single pathologist. Let them make blocks, and then there's blocks you can share for second opinions. Try to think that it is a metastatic tumor, so that if at all you're going to operate on the tumor, you could excise the biopsy track. And make sure you don't take multiple different entries in the skin, because then you could end up contaminating. So that is basically some principles about the biopsy. The biopsy can be transpedicular, interpedicular. Now you have to plan the biopsy where exactly you're going to be able to hit multiple different areas of the tumor without causing any damage to important vessels or any visceral structures, and able to get multiple different cores. Once you have the biopsy, you need to then, so now what do you have? You have the X-ray, MRI, you know what kind of tumor it is. You've done the biopsy, you know what kind of, what is the grade of the tumor, or what is the type of tumor. Is it a GCT? Is it a chondrosarcoma? All of these things you come to know in that. At this stage, something that you can do is you want to also know if it is spread across here and there. And that is where those tests come in, which we were talking about, and that is PET scan. Now, PET scan is a single scan where you will be able to see where all in the body the tumor is involved. Let's say you don't have a PET scan, then you don't have to get disheartened. You can ask for a CT scan and an abdo-pelvis scan, because this is primary where the other tumors can come across. And you can do X-rays of the long bones to see if any of the bones are involved. So there are alternatives to PET scan, but in today's day and era, PET scan is easily available, so it should be done. Now, when we start talking about do we do the PET scan first or do we do the biopsy first, it should ideally be the PET scan before the biopsy, if you are sure that it is a malignant tumor. But if you think it is a benign tumor, you do the biopsy, and if the biopsy has doubts, then you could do a PET scan. And that's how you decide between the PET scan or biopsy first. Once you have all of this in your hand...
Sir?
Yes.
Sir, can you come again about biopsy and PET scan first? Sir, that
okay,
thing, sir.
Fine. So by now you know that we need to do the investigations so that we stage the tumor. And we want to stage the tumor so that we can decide what should be the type of treatment. Should it be an aggressive treatment or it should be a passive treatment? Now, very important part about staging is, in the benign tumor, you want to know how locally aggressive it is, where MRIs and CTs are going to help. But in a malignant tumor, you want to know if there is a distant spread. Now, to find out if there's a distant spread, you want to do a PET scan. Sometimes when a MRI and a CT is overwhelmingly telling you that it's a benign tumor, you can directly do the biopsy of the tumor in order to find out what it is. And if it actually turns out to be benign, then you don't have to do a PET scan. But if it is doubtful on the X-ray and CT scan, that it could be malignant also, where you're not very sure. Like you see a GCT on a MRI and a CT. There you can't be sure if it is a GCT or if it is a chordoma. So that is a case where you would want to do PET scan first, because if PET scan is showing a lesion in the iliac crest, which is much more easier to do a biopsy rather than a dorsal spine, you will do a biopsy on a more accessible place. So that's how you decide between a biopsy and a PET scan. Okay. Now, once we have all these information, the last bit of the puzzle is to know how long the patient is going to live. Imagine you do a spine surgery in a patient where the recovery period is 6 months and poor guy is going to pass away in 6 months. It is not good to put that patient through that kind of surgery. Or on the other hand, a patient has a metastatic tumor from the breast into the spine causing paraparesis, and you don't do anything for that patient thinking that अरे अभी तो spine में metastasis हो गया, अभी तो कुछ होने नहीं वाला है, patient को paraparesis हो गया है, and that person ends up living 5 years, 10 years, then you have done a disservice to the patient by not treating the patient aggressively. So knowing how long the patient is going to live is a very important thing. And there are different types of scoring system which are out there, which is called as Tokuhashi scoring system, modified Tokuhashi scoring system, which basically looks at different criteria. So it looks at the clinical condition, how many areas of the spine outside the vertebrae are involved, how many vertebrae are involved, and based on this, and which is a primary site of the tumor, it can tell the life expectancy of tumor in metastatic spine tumor. So it can give us a general idea that if the score is from 0 to 6, you conserve because the patient is not going to live a lot. Or the score is from 12 to 15, you do a good surgery because there's a very high chance that the patient is going to live long. So these are few scoring systems which are there. The famous ones are Tomita's and modified Tokuhashi scoring system. Just once go through them. It's all available online, and you'll understand what all are the different things that you want to study when you are doing this scoring system. Once you have the score in hand, you know that, okay, this is a particular patient where the patient is going, there's a metastasis from the prostate, and this patient is going to live long because the biopsy is showing that the patient is going to respond to immunotherapy. Now let us do surgery for the spine. The surgery is going to be different if the patient is 70-year-old, and it is going to be different if a patient is 90-year-old. So one other important part in deciding the treatment for the patient, rather to decide how aggressively you want to treat the patient, is based on how fit is the patient. And there are few criteria which are there, like the WHO ECOG scores and the Korsnowski scores, which tell us which are the type of patient you would want to operate on and which of the patients you don't want to do anything. Typically, patients who are very disabled, requiring special assistance, or are very sick, requiring active support, or are confined confined to the bed or chair. These are the patients where they are at the fag end of life, and maybe a very aggressive surgery will not help them. Once you have all these things in your hand, you decide if you want to cure the patient or you want to give them a palliative treatment. Now, identify those tumor types where you want to operate. So as soon as you have all these instructions in front of you, if you have a primary malignant tumor, basically a tumor which is in stage 1 and 2, typically a tumor which has not metastasized, or you have a benign tumor like a hemangioma or a giant cell tumor which has turned aggressive, these are those juicy tumors which you would want to operate. At the end of the day, we are surgeons, so we love operating, and these are the tumors where you can operate on them. And when you're talking about curative surgery for tumor, it is always wide excision. So this is where the terminology of surgery comes in. There is something called as intralesional surgery, where you open up the tumor, you debulk the tumor from inside, and you close. That is called as an intralesional surgery. Then there is something called as a extended curettage in an intralesional surgery, where you remove it out, and then the end or the margin you burr out, or you put some chemical cauterizing agent, something to get that margin also removed. Then there is something called as a wide excision, or the famous O-block resection as it is called in spine, where you remove the entire tumor with good margins so that you know that there is no chance that you've gone into the tumor. And so these are the different levels of resection that you can do in a tumor. And when you're talking about spine tumor, curative surgery, you are basically talking about wide excision. Then there are those type of tumors which are not favorable for surgeries. And these are those tumors where either the tumor has metastasized, or the tumor is a high-grade tumor in an area where there is no chance that you're going to remove it, or it is in a tumor in a patient who is old, unfit, medical issues. All of these are non-favorable tumors, which means these are tumors where either you don't operate or you operate with the idea that you are going to keep the patient comfortable, right? Once you decide that, okay, this is a favorable tumor and you want to remove it, then you start thinking as a surgeon. Till now, you are not thinking as a surgeon. Now you think as a surgeon that can I remove it? If I remove it, is it possible to remove it completely without entering the tumor? And that's where you have that concept of a content tumor, the compartments and the barriers. So this is how your vertebrae is, and then you have barriers around the vertebrae, which are the intervertebral disc. You have got the posterior longitudinal ligaments. All of these are
Sir, video has gone.
Yeah, we'll just wait until he reconnects. Priyank, sir?
Hello, sir. Hello.
Yeah, we're waiting for Dr. Priyank to reconnect, I guess.
Harshal, are you there?
Yeah, I'm there now. Yeah.
No, suddenly something happened in the Zoom and it was saying that recording stopped. So are you able to see the screen?
Yes, we are. We are able to see your screen now. Yeah.
Just give me a second. I'm going to restart the presentation because I got some error message from Zoom.
Yes.
Are you able to see this now?
Yes.
Okay, great. So basically here, what you are trying to do is you want to remove the tumor without getting into the tumor, and you see that there's a cord over there. So what was done is that the axial cut of the spine is divided into several different zones, and there are few zones you want to keep tumor free. Only then a en bloc resection is possible. So basically, what you want to do is, let's say in your MRI, you're seeing that the tumor is involving the body and part of the pedicle. So that entire part you want to remove without getting in the tumor. So the other aspect has to be disconnected and removed, and that's how you have removed the entire body 360 degrees. And that's where there is something called as a WBB system. Uh, WBB system is basically a system, not really a scoring system, but basically it's a system in which your vertebrae is divided into 12 different segments. So whichever vertebra you're going to operate, you make a tracing out of that, and you will realize that it is going to fall in one of the zones. It would be in the zone 1, 2, 3, or 4, 5, 6, or 7, 8, 9, or 10, 11, 12, or multiple different zones. And based on the zone, they have given a clear idea about how you approach them. Do you do a all posterior approach? Do you do an anterior posterior approach? Do you do a left, right, anterior posterior approach? So whenever you're doing a tumor and you're doing an en bloc spondylectomy, remember that you open up the WBB system, take a tracing paper and trace the entire tumor on your tracing paper, sit with the tumor system, sit with the WBB system, and it will tell you exact steps how to execute the surgery so that you will be able to do the surgery. For example, let's say you have a lumbar spine tumor and that tumor is in the area of 7, 5, 6, 7, 8. So it's a pure anterior tumor in the lumbar spine. Now you want to do a en bloc spondylectomy. What are you going to do? How are you going to remove it? There, the WBB tells you that you go from posterior aspect, remove the posterior elements. Then, and when you're doing the posterior elements, you dissect out and separate out the body anteriorly on the left side and the right side. And then you go anteriorly and you deliver the tumor from the anterior aspect. So this is something, the surgical plan has already been set based on the WBB system. All you have to do is execute that. So typically, let's say how you want, if this is the type of tumor, like how it was shown in that scan, in this scan, how would we execute the surgery? We'll go posteriorly, we'll expose the tumor, then we'll disconnect the posterior elements from the tumorous part. And after removing the posterior element, we are going to remove of the normal pedicle and the transverse process. So now the only thing that is hanging over there is a tumor, and that is separated out and delivered from the back. So that's basically how you do an en bloc spondylectomy. The concept is something that you have to remember. En bloc spondylectomy, remember, is a very, very high-end surgery. And unless and until you are at a dedicated tumor center, this is something that you have to, not venture into. But you should all know what it is. So let's say there is a L3 chondrosarcoma. Now I'll tell you how I am thinking. L3 chondrosarcoma, it is a malignant tumor. It is going to be seen in an elderly individual. I'm going to do a PET scan because it is a malignant tumor to see if any other area is involved. There is no area involved. I have a biopsy proven thing that it is a chondrosarcoma. My idea is I want to remove that out completely. It is involving only the anterior aspect of the body. We do a all posterior removal of the tumor and we reconstruct it. At the end of the day, what you're going to see is that entire L3 vertebral body along with the anterior and posterior element is out of the spine. So that is basically what en bloc spondylectomy is concerned, and that's how your specimen is going to be seen afterwards. Similar type of cases which I'm showing where L2 spondylectomy was done, and that's how your x-rays are going to look. It is already published, it's out there, and it is a high-end surgery, lot of complications, lot of problems, but yes, that's an option. Now,
Sir,
what do we, yeah.
Sir, this whole vertebra comes out from the anterior opening, right?
Anterior and posterior both. So that's where the WBB system comes. You can do all posterior spondylectomy. You can do an anterior posterior spondylectomy. You can do a posterior anterior posterior spondylectomy. So there are different approaches that you can use for that spondylectomy, and it depends upon anatomically where the tumor is.
Okay, sir.
Okay.
Sir, excuse me. What is the full form of WBB?
So Weinstein, Boriani, and Boachi is what is the name of the. So they are the three doctors who have done a lot of work in tumors. They came together. They did so. What they did is they have been doing en bloc spondylectomies for years together. They compiled all of their en bloc spondylectomies and then came out with a consensus as to what type of tumor needs to be operated by what approach. And that's entirely what WBB classification means. Yeah. All right. Now, this is all good if the tumor is a favorable tumor. Favorable tumor means a tumor which needs to be removed, a tumor which can be removed, a tumor in a patient where the patient will be able to take that surgery. And when I tell you take that surgery, we have had blood loss of as high as 4.5 liters in patients where we have done en bloc spondylectomies, which means literally it becomes a mesotransfusion. You have to remember that your anesthetist, your hospital, everybody has to be ready for a high-end surgery. The blood loss in sacrectomies can be as high as 21 liters. That has been described in literature. So the point is that you have to be ready to, you should know what you're getting into. But let's say it's not possible. The patient is very old, the tumor is not accessible, or by trying to do en bloc spondylectomy, there's a risk to life for that patient. So they are not those favorable tumors. What to do for them? You cannot just leave them. And that's where all the other type of surgeries come in. Where one is called as an aggressive intralesional excision, which means you open the tumor and everything that you see is tumorous, you remove that. Okay, so that is called as a gross total resection. Microscopic tumor you're going to leave behind, but you're going to completely remove everything that you are seeing. Then there is something called as palliative debulking. Palliative debulking is basically you just remove off the tumor which is pressing on the cord, stabilize the cord so that neurological deficit is not there, and let the oncologist and radiologist take care of it. Not all tumors require surgery. So let's say if you want to palliate a patient, you know that the patient is an old patient, 90-year-old, paraparetic because of a lesion in the spine, zero power in the spine, and you want to give them comfort. Okay, and the patient is just now dealing with pain because of the tumor. You can just give a radiotherapy session over there. Radiotherapy kills off the tumor, and that's how tumor pain goes away. There are other surgeries also that are there, and that is basically clear the tumor from the cord and give high dose radiation in terms of SBRT, that is stereotactic body radiation therapy, wherein high dose radiation is given to that area to kill off the tumor. So here you're not removing the tumor, but you're killing it with radiation. So this type of treatment is now becoming common and popular for tumors which are classically radio resistant. Means conventional radiotherapy will not work on them, but SBRT will. Certain tumors, you just do a vertebral body augmentation like vertebroplasty for the instability type of pain that the patient has, and do percutaneous stabilization so that the remaining part of the life patient remains pain-free. So these are the different treatment options that are available where you are not able to remove the tumor. And so like...
Sir.
Yes.
Sir, when it comes to these tumor not favorable, sir, age expectancy is low and this radiation will have side effect. Why not, sir, just only morphine, pain control and those things would be sufficient enough rather than...
So that also is a part of the palliative surgery where you just give them painkiller, give them good food to eat and tell them to rest at home. So that, yes, it is a difficult thing to tell, but yes, that is also an option. But that is not a medical option. Like you're just giving them pain medicines. Any tumor, if there is tumor pain, a radiation can take care of the tumor pain. But let's say if radiation is not feasible, then you give them morphine and everything. Yeah, but that's definitely...
I was wondering about this radiation might have a lot of side effect thing, na? A lot of things might happen.
Not really. So conventional radiotherapy does not have a lot of side effects. When you use conventional radiotherapy to a radio-resistant tumors and you want to give a lot of multiple radiations, then you're going to have side effects. But radiation, when they are used for pain management, just palliative treatment, the dosage is very less. That's why there is no real side effects in those patients.
Thank you, sir.
Yeah. So like this patient is just... there's nothing that we really can do for this patient. There's a tumor which is spread all across in the sacrum, a very old person. We really can't do anything. And all the patient required was pain management. So injecting cement over there, and that's called a sacroplasty, helps. Preoperative embolization or embolization as a treatment is there for tumors. And so here you need to know what embolization is. And when you know what embolization is, there are two types of embolization, permanent and temporary. So basically what is done is that the artery or the blood supply to the tumor is cut off by a permanent element like a pellet, or a temporary element like a gel foam. So when you're doing gel foam embolization, it has to be done 24 hours prior to the tumor so that you have good results at the time of embolization. Whereas treatments like let's say therapeutic embolization for aneurysmal bone cyst, or therapeutic embolization for hemangiomas, you want to use that plastic pellets that are there, which are like permanent. So once it blocks that vessel, it is never going to open up again. So the embolization is at the treatment. So many newer gadgets are there now which helps us in treating tumors. So like let's say you have earlier patient where radiation is done and post radiation there is multiple fractures. You can't do anything for that patient because if you open up the skin, it is never going to close. But now with the advent of navigation, robotic, MIS surgeries and everything, all you can do is multiple levels MIS stabilization you can do without opening this spine. And you don't have issues of wound healing, and the patient still lives a pain-free life. You can use 3D printing to pre-operative plan.
Sir?
Yes. Hello? Yeah.
Sir, what about the green bottle?
Sorry?
So what was that green bottle?
So that is basically...
So what was that green bottle?
Yeah. So basically what that is now, that is a picture of the first generation Renaissance robo, which was, I think, Medtronic's ka robo. So that green bottle is actually the robo which goes over the spine. You can have 3D printed jigs. You can have 3D printed spine with which you can sit together and figure out where you're going to make the cuts, how you're going to approach the tumor. So this is going to help you plan the surgeries. You can become a bold surgeon when you are not worried about the neurology, and that's where intraoperative neuromonitoring comes in, where where when the neuromonitoring is okay, you can keep gunning for removing the tumor. When you're pulling the tumor from the paraspinal space, you know when to stop if it's causing a neurological deterioration, because the neuromonitoring starts getting affected. Navigations help a lot. Like you can do navigated guided burring for osteoid osteoma. You can put MIS screws in patients with post radiation. So all of these different tools are helping us do more and more surgeries and more treatment options for these patients with metastatic spinal tumors, primary spinal tumors, where earlier there was no treatment options. And that's what I told you in the start, that it is such a fluid branch that every day there are newer things that are coming up. And the journey started years back and it's still developing. And a lot of new things are coming up. Like India has now got proton beam in Chennai, and you are now getting carbon fiber implants which you put it in the spine for patients where you want to do proton beam. So these are newer things that keeps coming up, and you have to be continuously updated. And whenever you are treating a tumor case, remember what I had told you in the start, that you have to start thinking about a tumor surgeon, not get lost. Remember, what you need to do is you have to investigate the tumor to find out what kind of a tumor it is, where or it is located. You have to do a biopsy of the tumor to find out what grade and what type of the tumor it is. Combine all of that together and stage the tumor. After staging, find out how long the patient is going to live. Is the patient fit enough for what you want to do? And at the end of the day, come out with a plan if you want to cure the patient or palliate the patient. And then you decide if you want to operate, you want to do chemotherapy, you want to do radiotherapy. If you want to do chemotherapy, you want to do it before the surgery or after the surgery. If you want to do radiotherapy, you decide you want to do conventional radiotherapy or different other forms of radiotherapy like proton beam, carbon ion, or SBRT. So that's basically a synopsis of how you deal with spine tumor. And let me tell you, the gravity.
I think he's disconnected again, so we'll wait for him to conclude.
Sir, can you throw some light on the proton beam therapy? What is it?
So basically, we have a lot of advances in management. So gamma knife, proton beam, argon laser, all these things are basically advancements in radiotherapy. Proton beam, we have no experience because the first time it's come to India in Chennai, but there are many spine centers across the world where it's been used regularly. Yeah. Got it?
Hello. Hi guys.
Yes.
Sorry, I just exited for a minute. So basically, it's such a niche branch that even at one of the top referral centers of our country, we still have a discussion whenever a spine tumor comes in. So it is something that requires constant attention and constant reading and updates. So that's basically a summary of how to deal with spine tumors. I know it's too much to grab in one day, but that's how the topic is. I try to simplify it as much as I can. Do you have any doubts?
Sir,
you guys
one question.
Yes, Virendra.
Sir, do you use the neoadjuvant therapy in spine metastasis or spine malignant tumors?
Yes, we do. So surgeries like where we are doing surgeries for GCT, surgeries for osteosarcoma. These are surgeries where we do neoadjuvant treatment in form of either denosumab or chemotherapy before doing surgery. Yes, we do it in certain tumors.
Sir?
Yes, Nitin.
Sir, other than reducing the size of the tumor before surgery using chemotherapy? Or sir, is there any other rationale to use chemotherapy or radiotherapy before entering into the surgery, sir?
Yes, it is. So let's say if you're operating a case of osteosarcoma and there is a chance that the tumor spills over, right? If you have done a neoadjuvant chemotherapy, you have actually essentially downgraded the tumor a little bit. So in case also you end up spilling, the chance of a profuse metastasis goes down. So in tumors which are sensitive, like Ewing sarcoma or osteosarcoma, there is definite role of doing a neoadjuvant treatment. Then if you're, let's say, operating a giant cell tumor and there's a slight chance that it is going to spill over because it's like glue, if you have given denosumab earlier, then it becomes like a rock solid cricket ball when you're removing it. So there is definite chance, or there is definitely an advantage of doing neoadjuvant treatment in these patients.
Thank you, sir.
Sir, what is your experience in treating the different kind of metastatic tumor in spine, like metastasis from the prostate tumor or breast carcinoma, or sometimes lung carcinoma? Which is better longevity wise, and what is your experience?
So I'm liking it the way you're thinking. Now you're thinking that if there is a metastasis tumor to the spine, how do you treat the different types of tumor? And this is exactly where that scoring system comes into picture. So if you see the modified Tokashi scoring system, you have different aspects in that. One of the aspect is where the primary tumor has come from. Now, when you treat tumors, you know that that let's say a lung metastasis is not a good prognosis. The life expectancy is very less. Whereas, so life expectancy can be anywhere between 6 months to 5 years. If it is a high grade tumor, then that's bad news. Patient will pass away in 6 months. So that is one bit. On the other hand, prostate and breasts have very good results. So if you have patients with metastasis from prostate and breast, you have to be very aggressive. Whereas if it is from lungs, you have to be passive, because you know that how much ever effort you're going to put on that patient, he might not live that long to appreciate that effort.
Priyank, I would like to make one
Yeah.
here.
So let's all of us start our video, whoever are there, and in the discussion, because we'll have some discussion about these questions, and then we'll have one or two mock cases for training our mind to plan on tumors. Yeah, Aditya.
So recently, just 2 days back, I saw one patient, elderly lady, around 65-year-old, with back pain and history of trivial fall 1 week back. She came to me with severe back pain and showed to local orthopedic surgeon, where they suspected something is wrong. So that's why that orthopedic surgeon referred to spine surgeon. So that's why they came to me. I saw the MRI, and to my surprise, because the history was suggestive of more of osteoporotic compression fracture, so I was anticipating as per the history. Neurologically, she was absolutely fine. But to my surprise, on MRI, I saw it was a pathological fracture at T11 and L1. And whole spine was showing, even C3 was involved, fracture. Cord compression at all those levels were not much. It was just indenting the cord, and that's the reason maybe the neurology was intact. But I suspected something is wrong. It's not a usual looking osteoporotic fracture. It's looking like a pathological fracture. I admitted the patient first. I counseled them that we are dealing with something more than the usual fracture. So we need to look into that clearly. We did the PET scan. Before PET scan, at the same time, I involved oncophysician, because I felt that something is going on. So even the oncophysician examined, and she found there is big mass in her right breast. So it was a primary breast cancer which got metastasized, and even the PET scan confirmed that. We did breast biopsy. Biopsy report came as infiltrative intraductal carcinoma of breast, which was ERPR highly positive, so which was in our favor. So the oncophysician said that just giving hormonal therapy will help her. And if spine point of view, if you are sure that nothing needs to be done, because there was no instability, there is no neurology. So I prefer to keep her in bed maybe just to protect that fracture. And we have given her hormonal therapy. And so this is just I wanted to say that many times we just go by the MRI picture where the fracture is, and we just as a surgeon we try to think in terms of surgery only. But in tumors, as you rightly said earlier, also that it has to be a case to case basis, and if at all radio, chemotherapy, or non-operative treatment has got more role, then we should prefer that over surgery in such cases.
Absolutely. And it is and the steps that you took were absolutely right, and they are going to these steps are something that is going to have excellent outcome in patient. Let's say if it would have been the other way around, if this patient would have gone to an oncologist first, what that oncologist would have done is not cared about the spine. That oncologist
Correct.
would have treated the breast cancer, ERPR positive, which means that the patient is going to have a good prognosis. But that patient, the oncologist is not trained to look at the spine, the instability, and then imagine the patient has a fracture. So
Correct.
the tumor is getting better, but the patient unfortunately is landed up with a paraparesis. That is exactly
And
why
in
when the spine is involved, you take the
yes,
onus on yourself and you take the decisions. You tell them that, boss, this patient is a stable fracture. I'm sending the patient across. The patient has breast cancer proven on biopsy. Kindly start chemotherapy. Versus you
correct.
send to a radiation oncologist. If suppose you feel that no, this patient requires radiation, like it's a plasmacytoma, you go take radiation for this patient. And this is how, because you know your spine better than them, and that is where you will be able to treat them better.
And when I discussed the case with oncophysician, she clearly said that she has got very good chance of leading her life normal, very
Oh,
good
absolutely.
prognosis.
Oh,
So,
absolutely.
just to check the anatomical structure-wise, how much destruction the tumor has caused, we did CT also. So it was absolutely stable spine. Just it was a fracture, pathological fractures, but so there was no indication of surgery. And let's see how patient does. I'll have some follow-up in coming months then.
Superb. And now, if we have some energy, let's have some case discussion.
I would just
Uh,
want to make one point
yes,
here.
Harshal.
Yeah. So the most important aspect or takeaway for me from this discussion by Dr. Aditya is that it is important to understand and read the MRIs, X-rays well. Like your mind will only know it when your eyes will only see it when your mind knows it. So I
Correct.
think the most important takeaway is that look at all the images, T1, T2 stir. Don't just look at T2 sagittal and have your diagnosis. Look at all the images. Look at the X-rays. Do CTs whenever required, and have an open mind, because most of the times we tend to miss these things. A simple kind of a pedicle miss sign on a X-ray can give us so much of information. So radiology, just from this lecture, I think we cannot cover everything about
Yeah.
tumors, but important to look at the X-rays and see whichever X-ray come across to you.
No, tumors
Absolutely.
is a very complex topic, and but the idea of today's thing was how do you approach a case of tumor? Because once you know how to approach it, executing it does not become that difficult. And on this aspect, let's get Kedar, Harshal, Nitin. If you are still there, Vijendra, you guys were interested in the tumors. You guys can actively participate. Nishant, are you around?
Yes, sir.
Yeah, so I would request Nishant to put up a case. And see, I'm not going to talk because I know about it, but I want Harshal, Aditya, Kedar, all of you, all of
Sir,
you
your
are
voice,
around.
Hello, sir. Hello, sir.
you have a
Your
lot of
voice
reverberations.
Nishant,
Yes, sir.
देखना कुछ
Am I audible?
you are,
Are
I don't
audible.
know where this echo is happening.
Okay.
Nishant, try to talk. I'm going to mute myself.
Yes, sir. I'll share my screen for the case.
Is it happening?
Somehow I am not able to share my screen. I'm trying.
Okay, so in that case,
Apurva,
you can put it up. Is Apurva there? Yeah.
Yes, sir. Hello. So I am putting up a case.
So Aditya, Harshal,
Try to put up that.
Kedar, I want all of you to start telling how to proceed. Not too much discussion, quickly. 5 minutes, one case. 5 minute, other case. Come on.
Apurva, you're putting up the case?
Yes,
Otherwise,
sir, I'm
Kedar,
trying
you
to
can share your
share my
screen.
screen.
I'll start sharing mine. Apurva,
Do that.
wait. I'll start sharing.
Yeah. Sir, you have that presentation?
No, so Kedar's got a presentation. He'll present. In the meantime, you can get it sorted out.
So I think now my screen should be
Yes,
visible to everybody.
yeah.
Okay. So the first case I present is a 29-year-old male. He came to our OPD with mild complaint of swelling over the supraclavicular area and some on and off mild mid-back pain with a little tingling over his left upper limb on and off, not throughout the day. This is the basic.
Full screen. Yeah, perfect.
On examination, gait was normal, neurology was completely normal, range of motion was good, Spurling's was negative, planters and reflexes were normal. Based on this, how would most of the people present here today proceed? What would be the next thing that you do, or what would you like to look into?
Actually, you want to take it up?
Yeah, basically X-rays and MRIs and basic investigations, because patient has come to you with some pain and some symptoms.
Yes.
So basic radiology first of all.
Absolutely right. We followed the same parameters and got a basic chest X-ray done. So on the chest X-ray, we did notice on the left side there was a lesion around the D1 spinous process and D1 transverse process and the first rib in that area. We also got basic blood parameters done. The blood parameters were within normal limits. Now, how would you like to proceed, sir?
So can you point out what was seen on this X-ray?
Can you actually see the arrow that is marked? So there was just like a lytic lesion seen over there, which was more like a shadow, not a very clear picture was noted on the X-ray alone.
Yeah, got it, sir.
Okay. So the next images that you have?
Yeah. So based on this was a very basic investigation. So we further proceeded to get a CT scan done. Okay. So on the CT
Nitin,
scan,
what do you see over here?
Yes, sir. Sir, on this CT scan, sir, on the left side there is a expansile lesion. Sir, I don't know from which bone it is coming. I don't know which bone.
So it's either it's one of the vertebrae. So, but it's an expansile lesion coming from one of the vertebrae, correct?
Yeah. It is an expansile lesion coming from one of the vertebrae, and the content looks heterogeneous in nature.
Okay. Very good.
And there is conspicuous bony margin present almost all around intact. However, there is some bulge. There is some ingrowth which has happened into the thorax.
Very good. Excellent. What else? So you're there. You've actually described all the important points which I was talking about. Kedar, any other points you want to highlight for them?
So on this, on the CT scan, we did note the size of the tumor. Also, that there was a good bony margin around most of the tumor. However, if you start looking at the axial cuts, there are lower down. You can see in the images that it is it's actually very close to the major vessels, specifically the arch of aorta. So that was a very big concern based on this CT.
Correct. So basically that same principle is when you're looking at the tumor, you look wide and see what is happening in the periphery. And like you and Nitin said that it's calcified, but there are places where they are in touch with the big vessels. All right. Okay. Let's go next.
So after this, we further got an MRI screening done as normal protocol. On the MRI, it was confirmed that the tumor was present, and also the soft tissue margin. There was some amount of tumor which was not completely calcified or did not have a complete bony margin.
Perfect. So Harshal, what do we do now? Like next step?
Definitely a PET scan and biopsy, both.
Fantastic.
One after the other.
So we do both of them. Why a PET scan is because you think it's an aggressive lesion in the spine. You want to see if it has metastasized or not. And biopsy. Kedar, you did that. What did you find?
Yeah. So we first got a CT guided biopsy done. The biopsy did show a report which said that it was a giant cell tumor. Also the CT scan did note that it was very close to the aorta.
Correct. So basically now you are in a fix. You have a giant cell tumor. You know that it is a benign tumor, but it's an aggressive tumor. So it comes in the stage 3. And also you know that the lesion is in contact with aorta. So technically it becomes an inoperable tumor. So that is where you are at. It is a tumor you want to remove, but it comes in that unfavorable tumor types. What would you do? Aditya, you're there. What in this case would you want to do? Or Harshal or anybody?
So basically here I would
Nitin,
like...
you also can add in. You had pointed out these things.
Sir, denosumab, sir.
Why denosumab?
Sir, since it is a non-favorable type, and the tumor has somewhere leaked and it is in touch with aorta. So when we want to work around, we just want to have some plane between aorta and the tumor thing when we are removing. So with this thing and on MR scan, the echo texture was heterogeneous in nature. So it seems कि वो काफी vascular है.
Okay, so you want to give denosumab because you don't know what to do now, correct? Why can't we just do a basic debulking of the tumor, reduce the size of tumor? Why are we even operating on the tumor? It is not causing any problem. The patient just came with some chest pain. Painkiller दो और छोड़ो उसको.
सर वो ना intermediate variety का tumor है, aggressive है, तो ये बड़ा हो जाएगा और क्या पता लगे कि अयोटा में घुस जाए तो फिर और प्रॉब्लम कुछ ना हो ही जाए. तो इसीलिए वो अयोटा को तंग करे, उससे बढ़िया है कि मैं जाकर के अयोटा से बच के उसको निकाल के
Correct. So you do have to remove the tumor because the patient has tumor pain. It is going to grow. It is going to cause pressure effects and eventual problems. So it needs to be treated. You want to give denosumab. Aditya, what is your protocol? Do you give denosumab in these patients?
So basically here you know that it's a locally aggressive tumor, and it started off with the upper thoracic. I don't know the exact what level it started from, but it has grown up to the you can say thoracic outlet. So it is growing in size and maybe started coming in contact with your brachial plexus or roots. So that's the reason why patient is having upper lip symptoms. So I feel we have to be aggressive here. As a surgeon, we should think of doing excision of this mass. Maybe involve thoracic surgeon in your surgery since it is close in vicinity of your aorta. So take help of the thoracic surgeons. Plan your surgery either here, and I would directly go for surgery rather than waiting for denosumab result to come.
Okay, fine. What would you do? What you have done? Just let us know, Kedar, because we have one group
just
do
one
surgery,
question for me.
Yes.
Just one question for me. Would you, Dr. Priyank, before planning a surgery, want to give denosumab?
Yes. So that's exactly what that discussion point was. This is an inoperable tumor, in a locally aggressive tumor. So how I'm thinking is that by waiting for some time, this tumor is not going to metastasize. If I go ahead for surgery right now, I am going to leave tumor behind, because giant cell tumor is a soft tissue tumor, and because it is all connected with the aorta, I cannot pull out everything from the aorta because that could be a risky surgery. That's why I'll have to do a debulking surgery. On the other hand, we know that denosumab helps in shrinking the tumor and getting a good calcific shell. That is why I would definitely give denosumab in this patient and see what happens with time.
And
My
what is your
usual
protocol of providing
my
denosumab? What is your dose?
So my usual protocol is give 120 milligrams every 15 days for 3 months and then review and see. In general, in literature, there has been no complete consensus on how long you want to give denosumab before the surgery. But so we give at 6 weeks, we see at 3 months, we see. Basically, we keep repeating the CT scan to see how much the tumor has shrunk and how much it's calcified. If it is shrinking, I keep giving it. And if it is completely calcified, then I know that further shrinkage is less likely. In that case, I would do the surgery and get it out.
Yeah. And Dr. Kedar, was any MRI or CT angio done?
Sir, a CT angio was not done per se. No, sorry, a CT angio was done for him, and
did
an
you find
MR also
any?
was done.
Did you find any association of this tumor with the aorta? Any
Yeah, so there was the CT angio did show that the tumor was in contact with the aorta
and the subclavian artery as well.
And subclavian artery as well.
Perfect.
So
this is a very classical location of a Pankos tumor. I think this is the exact location where it is. For us, it's something new, but I think oncosurgeons typically do these surgeries very commonly.
Correct. So, Kedar, tell us what you did.
Further, we got a PET scan done to rule out if there is any other, the tumor has spread anywhere else or any other tumor is noted in the patient, which was not found. Further, we, as Dr. Priyank said, we did start the patient on denosumab since the patient was inoperable to start off with. We gave denosumab ex-Jiva over a span of around 6 months or so and repeated the CT. So both CT cuts I have put actually next to each other. You'll be able to see on the lower part of the slide. The tumor did shrink in size significantly, which was verified by the radiologist at that time. At this point, we actually had a chance to operate the tumor. So at this time, we kicked in our other teams at Jupiter Hospital and brought them into the picture. So the radiologist, the oncosurgery team, the cardiothoracic team, and our team sat together, decided as to how to approach the tumor. From this point, we were then planning to operate the tumor. The dilemma that came to us was whether to go anterior only. Should we go anterior after that posterior, or posterior first and then anterior?
So finally, what you did, just describe the surgery.
After a lot of discussion, we decided to go posteriorly, dissect the tumor out, stabilize the spine from behind. Once this was done, we closed it off and turned the patient over, went anteriorly through the clavicle. We were able to gradually dissect the tumor mostly with hand to begin with. In this time, we had our cardiothoracic colleagues on standby as well. And we were able to deliver the entire tumor out anteriorly. These are the post-op images, wherein for academic purposes, we also got a CT done again, which showed that the entire tumor was taken out.
Fantastic. So basically,
had you done the embolization process before doing surgery?
No, in this patient, we did not plan to go ahead with an embolization.
Why not? You can stop the screen share. There's nothing that you have to show after this, right?
That's just the take-home message. So that's about it.
Okay.
That's it.
Fine. So you shut off the screen share. So this is that exact case which tells you that how, by knowing about the tumor, knowing the adjuvant treatment, the neoadjuvant treatment, you can take that decision. So one, it is a giant cell tumor. It needs to be removed. It reacts to denosumab. By giving denosumab to this patient, we were able to shrink the tumor, calcify it, get a plane between the vessels, since we are targeting to do a wide excision or an en bloc resection, we were not going to go in the tumor. So there's no scope of embolization. And because we knew the principles of tumor, we were able to make a plan, and that's how we were able to remove the entire tumor en bloc. Whereas if it would have been just the onco team, like what Harshal said, this is a very common site for Pancoast tumor. And the approach for Pancoast tumor is you do it anteriorly. But if they would have done it anterior first, then we would have had to definitely leave back a little tumor.
So I
But
think,
since-
sir, I'll butt in here just for one second. What you're saying is so very correct. And I think guys have to understand that they should have read the CT scan much better. That CT in couple of cuts shows that there's an involvement of a vertebral body. There's an involvement of an adjacent costovertebral joint. And that is why the posterior first surgery kind of detached that, and then an anterior en bloc excision was possible. So I think that reading of the CT and MRI is so important, and that's what your team did well.
Correct. So that's basically the take home from this case, that if you apply all the principles well, you will be able to have a very good plan, and you will be able to execute it very well in the best interest of the patient.
Sir,
yes.
सर पहले पोस्टीरियर ही क्यों और फिर एंटीरियर? अगर कोई एंटीरियर से करके पोस्टीरियर चला जाता तो सर?
बिकॉज अगर पोस्टीरियर से करके हमने वो ट्यूमर को बॉडी पे से डिटैच कर दिया and then anteriorly हमने उसको निकाला. If you try to do it the other way around, anterior से there was no way कि हम body तक जा सकते हैं. That's where that anatomical and surgical planning is important.
Got it, sir.
And that's where that WBB classification will give you an idea कि कहाँ पे पहले posterior जाने का, कहाँ पे पहले anterior जाने का. Okay. So I think we'll call it for today, because it's been a long session, and tumor is always all around. But if you have any questions regarding it, please put it up on our group. We are happy to keep answering them. If you want some classification systems, you tell us what you need, and we'll keep updating on the group.
Yeah, rightly. Actually, guys can put up X-rays and MRIs of the tumors they have seen, and then they can discuss.
And we can help plan
to involve.
Yes.
Yeah.
Okay. Perfect.
Thank you.
Signing off. You guys have a fantastic whatever is remaining of the day today.
We made sure that match finishes before we start.
Yeah. We meet next week now.
Thank you, sir.
Chalo.
See you guys. Good night.
Thank you. Bye. Good night.